Welcome to the Turd Nerds. We are the functional gastroenterology podcast discussing all things poop. Before we take the plunge into today's episode, let us tell you a bit about ourselves. I'm Dr. Rebecca Sand, a naturopathic physician and acupuncturist, and I specialize in all things gastroenterology, hormones, and fertility.
I'm Dr. Ami Kapadia, and I'm a medical doctor trained in family medicine and functional medicine with a special interest in gastrointestinal health, food and environmental allergies, and autoimmune disease.
And I'm Dr. Gurevich, a naturopathic physician and acupuncturist who is board certified in naturopathic gastroenterology. I specialize in inflammatory bowel disease, IBS, and other functional digestive disorders. Let's jump into today's episode.
The following discussion is for educational purposes only and not intended to diagnose or treat any diseases or conditions. Please consult your doctor before incorporating any of this information into your care. The information presented on this podcast is not medical advice.
Okay, welcome back, Turd Nerds. I am especially excited. I feel like we say this every time.
Yeah,
but I am really excited about today's episode because we are doing biofilms. And I think we all treat this quite a bit, but I have about 105 questions. So today, Dr. Alana Gurevich...
105?
105.
Okay.
Give or take
a
couple hundred. Dr. Alana Gurevich is leading this one because she is the resident expert here in this. So take it away, Alana.
This is a big thing. You know how when you're in clinical practice, there's like this thing that you learn about that all of a sudden you start thinking back at all the patients that you've had that didn't get better. And you're like, oh, this is why they didn't get better. This is what biofilms is.
I feel like it's super controversial too.
Like I don't know if it's controversial in research. It's super, we are very clear.
I think clinically
treat it so different.
Yes, that's for sure.
There's potential to make people worse, but not most of the time, but occasionally.
I don't know if I have that experience. Okay. Honestly, I don't know if I have that experience.
Yeah, we do have different patients.
That's a very good point. We do have different patients.
Okay, can you tell us what a biofilm is?
Yes. Well, why don't we go way back to the beginning? And in my opinion, the beginning is bacteria. Bacteria, we know as a fact, is the oldest living organism on Earth. It's been here for billions of years. Just for a counterpoint, humans in the modern form have been around for roughly 200,000 years. So what we know about bacteria is they've been here longer, and if we're honest, they're smarter than us. Bacteria has this ability to be in these two separate states. Mm-hmm. One state is the state that we assume based on our antibiotic prescriptions and other prescriptions, which is a single-celled organism. Mm-hmm. That's bacteria in the planktonic state. That is one bacteria floating around by itself, doing everything that it can do as a single species.
That we
right?
can reach with antibiotics.
That we and you know, like the example that I always give is when you have a urinary tract infection, they're going to ask you to collect your urine, and then they're going to culture it, right? Mm-hmm. And then what's probably going to grow out is E. coli, because that's what usually grows out. That E. coli that's growing out is in the planktonic state. It is a bunch of single-celled organisms of bacteria. About 20 to 30% of bacteria live in the planktonic state.
Oh no.
The way that bacteria actually live, it's worse than you bet. The way that bacteria actually live and what makes bacteria so much smarter than humans is they have the ability to change from this planktonic single-celled organism to building a city and living as a multicellular organism in the biofilm state.
It's kind of scary.
And you're talking about, Alana, separate from other pathogens as far as the oldest organisms like viruses, fungi, protozoa. You're specifically right now talking about bacteria, but when you go into this, you'll talk to us about other biofilm communities.
So the reality is when we're talking about biofilms, we're generally not talking about just bacteria. We are generally talking about this multicellular, multi-species like environments that forms within the body and also outside of the body that affects health and gives, single cellular organisms or bacteria. I'm going to talk mainly about bacteria because we know more about the literature about bacteria, but no, they're generally in multi-species communities.
Like a uncomfortable family of
so there is pathological and there is physiological biofilms.
Right.
Humans can't live without physiological biofilms. The microbiome of the large intestine is a great example. They make environments that are more hospitable to them than they are to us within our environment. Whenever I'm talking about this, I always like to give the example of humans because my theory is that humans are an Earth on the biofilm. Sorry, a biofilm on the Earth. Humans are a biofilm on the
Okay.
Earth. We come and we build these cities and we build these very big brick houses. So when it's blizzarding outside, it doesn't really matter because we are in our safe house with our heat on. That's exactly what happens with biofilm communities. Bacteria and other species come together and build walls around themselves to protect themselves from the elements. They also, as they build these walls, become these very, very complicated multicellular organisms where a lot of different species of bacteria will specialize in different roles, just like humans will, there's our plumber and our electrician and our doctor and our teachers. We also hyper specialize so that we can live in this multicellular or multi-diverse communities that we live in and thrive with our species. That's exactly what's happening with bacteria.
So are you saying that we have data saying that the bacteria differentiate?
Oh, yeah.
Further?
Oh,
Wow,
yeah.
that's
It's like a
mind-blowing.
hyper specialized community. So I want to get to quorum sensing in a minute and auto-sensitization of the language that bacteria speak. But the first thing that I want to say is, the actions of bacteria when they're in a biofilm state are actually quite different than the actions of bacteria when they're in a planktonic state. So just because E. coli acts the way it acts in the planktonic state and gives you a UTI does not mean that E. coli within the biofilm is going to act in that way. The other thing that makes biofilms incredible is bacteria has the ability to share DNA. So if you have a planktonic bacteria that survives a course of antibiotics and develops antibiotic resistance and then forms a new biofilm community,
over.
and it's not just E. coli that now has the ability to be resistant to the antibiotic. It is the Pseudomonas and it's the strep and it's the staph because they can all share.
That's
I mean,
brilliant.
which is, one of the problems with antibiotic resistance is probably part of that mechanism. And I'll just throw out there, we might talk about this, but there are healthy biofilms in the body as well, which you probably will talk about.
We will definitely talk about that.
Which is one of the reasons I think sometimes we get adverse effects when we mess with biofilms in
really
general,
good point.
but...
that makes sense.
Yeah.
I think that, well, let me get there.
We'll get there. Yeah.
Um,
Jumping ahead of ourselves. So
The most
it's too exciting.
important thing to know is that biofilms are filled of densely packed communities of species. We're mainly going to assert bacteria in this episode, but of species, and they are complex in nature, they are diverse in nature, they are coordinated in their actions in nature, and they basically become a multicellular organism. Like, that's kind of the most important thing. We see biofilms in the body, but we also see biofilms on the earth, right? So an example would be like when you're by a river and the stones are slippery.
Totally.
That's a biofilm.
Gross.
Or when you have piping in a house, not gross,
Right.
alive.
The piping one
but
is
when you
gross.
step in them,
Yeah.
pretty gross.
Or like when you have a pipe and the pipe gets like occluded, you know what I mean? That's a biofilm.
So can mold do this?
Mold, absolutely. And if we're talking about candida or actually just other funguses, they are one of the most important.
Right.
I think particularly on catheters and such.
That's exactly where all our data is at. Our data that we have on biofilms, which is why this is not at all questionable in the literature, our data is on surgical sites and then devices. Catheter devices, implantable devices, prosthetics.
So problematic.
So problematic. And it's like that's where we know this is happening. You know where the most obvious clear biofilm is?
On the teeth?
Yeah, that's what I think of.
Plaque on your teeth.
Yeah.
That's my favorite way to explain biofilms to patients. All
Mine
of
too.
us. Okay.
You go to the hygienist and she scrapes your teeth and all of a sudden there's like air that's flowing through your mouth that wasn't there before.
Very relatable.
And then 3 weeks later, those holes are closed down again because the bacteria has rebuilt that structure around itself to protect itself. Other interesting things that happen in biofilm communities, not only do they share DNA, but actually their rate of reproduction is very slowed. So depending, because the biofilms are so densely packed, sometimes you have bacteria that, will, like in a planktonic state, will reproduce very rapidly. But in a biofilm community, the reproduction is grossly retarded or slowed.
Conserve that energy?
They conserve that energy. And that's really important because we think about like a round of antibiotics.
Right.
If you have a species that's not reproducing as quickly and is much more slowed, then what you end up having is more options, more ways to be antibiotic resistant.
Right, because the efficacy of the antibiotic depends on the reproductive rate of the
Less
organism.
metabolically active. So
Harder to eradicate.
Yep.
So there's a couple of important key concepts that I feel like clinicians need to understand. The first is known as the EPS matrix, right? The EPS matrix is basically the goo that the bacteria makes and secretes this is the houses. The EPS letter is like our houses. It is the material that protects the bacteria who are living within that biofilm community from being exposed to the elements of your digestive system or your mouth. This is really important because the other thing, because really why this is an issue, or one of the reasons why this is a big issue, is because of antibiotic resistance.
Right.
We are in a full-fledged arms race with bacteria. The bacteria, there's no question about it, is winning. We are not keeping up with making new antibiotics. The antibiotics that we are making that are new are not more specific or pointed, and oftentimes they're just wiping out more things. And the bacteria can, A, slow down their growth, and B, exchange DNA with each other. And so that's why we're talking about this. Basically, that all comes down to the EPS layer. If you are comfortably living within your building or in your house, you can come and go as you will. You live in your, biofilm community in your household. You walk to work, that's your planktonic state. You ride the bus to work, that's your planktonic state. But that EPS layer keeps you away from the elements. That is important because one of the things we do when we're working on treating biofilms is breaking down that layer.
Did you say what EPS stands for?
EPS stands for extracellular polymeric substances.
Okay.
So basically it's goop.
Yep.
I mean, for all intents and purposes, it's goop. It's like plaque on your teeth. It's hard. When biofilms form, generally they'll form in a moist environment with something solid. So like the rock in the river, right? The rock is hard. The river is fluid that lets things move. And that's where it's happening. Our mouth is moist.
It needs something to adhere to.
It needs something to adhere to. Yeah. That can also be the intestinal lining. That can also be the mucosa. That can also be the ears.
So mucous membranes. Prosthetics.
Exactly.
Yeah.
So the EPS is really important because that is the structure and the backbone for these biofilm communities. Do you guys want to know how it forms?
I kind of am grossed out, but yeah.
It's super interesting. Okay, so here, there's a couple of things to know about bacteria, right? They're single cellular, right? Which means there is not very many activities or ports for communication. But every bacteria that we have ever discovered seems to have two different receptor sites. One receptor site is a way to communicate with other bacteria within its same species. But every bacteria has a port to communicate in like a bacterial universal language.
Like in the jungle with the animals.
Tell me more. Tell me more about that.
We'd have to watch some documentaries. Go ahead.
So basically, bacteria release this hormone called autosensing. And it's called quorum sensing. So bacteria will all kind of float around and surround some kind of, mucous membrane or...
It's like a bacteria conference.
Right, it's like a bacteria conference.
Yep.
And when enough bacteria get there, they start secreting this hormone. And when it gets packed in enough hormones are secreted that everybody says, okay, yes, this is our new location. Yes, let's start building the city. Wow. Yes, let's bring the guys over to build the EPS layer. Yes, let's build the guys over to make sure nutrition's here. And so it's through quorum sensing that the bacteria is speaking this universal language with each other.
Collective brain.
They get a collective brain. That's exactly what a biofilm is.
Yeah.
It's a collective brain.
It's like zombies.
It's like
the zombie.
You know what it's like?
The intestines.
You know what it's like? Do you remember Star Trek? Resistance is futile.
Yeah.
What was that? The Borg?
I feel like we better get on to treatment here, Alana, because I'm feeling a little hopeless.
A couple of thoughts. One is, so I don't know if you read about this at all, Anna. Do they think they're in part we form biofilms as a safety mechanism to sort of wall off certain communities to keep them less problematic for the rest of the body? Because that was one of the theories as to why at one of our conferences they said we can run into trouble if we start busting these open, is because our body has this mechanism that it's trying to keep these organisms in a less sort of pathogenic state.
Okay. I feel like my answer is I don't know. I haven't read that. What I feel like is when we use the word we, I feel like that's a facade because let's be honest, the we is the bacteria.
Okay.
Right? Like
we're more bacteria.
We're more bacteria than human.
Right.
I feel like bacteria has an internal preference of living within a bacterial environment.
Right.
Right? And they're like they're just basically utilizing us. Like, I don't know, do you guys ever get like, okay, let me just tell you a quick story. I was really pregnant and I was going in to see my midwife in the morning, and I had my usual breakfast, I'm a high protein breakfast, my Ezekiel bread and my eggs and my cheese, like high protein. And then I go in to see my midwife, and she does like a pelvic, because she's like checking me, no. She does a UA, because they did a UA on every visit.
You want to share this?
I do.
Story?
I definitely want to share the story.
Go ahead.
She does a UA, and she was like, "You've got a lot of glucose in your urine. What did you have for breakfast?" And I was like, 2 eggs and toast and a chocolate bar and honey. And she was like, "I think you have a yeast infection." I was eating so crazily off of my diet because I had a fungal overgrowth, and the fungus was controlling my food desires.
Right.
Totally.
We are more species.
Microbes.
We are more microbe than human.
Yeah.
Right.
So my response to you is, I don't think there is a we. Right. The other thing I'm going to say is there are physiologic biofilms that are just, in fact, a lot of the bacteria within our species have these physiologic biofilms. And there's even data that shows that physiologic biofilms are protective against pathologic biofilms. They'll wipe them out.
Yeah, I was going to ask, do they fight each other?
Yes. And I will tell you that we do a really good job in our current Western life and society. We do a really good job giving the pathogenic ones a foot up.
Totally.
We use antibiotics.
Right.
We use pesticides.
Poor diet.
Antiseptics.
Inflammation everywhere.
But also, like, I think about the commercials, the Lysol commercials, where they're like explaining that, and they're like 99.9%.
Yeah.
Killing everything.
Sanitizer everywhere.
What are they killing? They're not killing everything.
Right.
They're killing all of the things that we live in synergy with, and they're leaving everything else.
Yeah.
Does that make sense?
I'm surprised, actually, that any of our antibiotics work anymore.
I am also surprised that any of our antibiotics work anymore. I will also tell you that from my data, from what I understand in the data, I don't think herbal antibiotics are the same.
Correct. They seem to be they seem to have less resistance forming capabilities because of it's the whole plant and all the things that I'm sure you'll talk about.
They're not as specific. They've been around for as long as humans, if not longer.
And the plants have to protect themselves from the pathogens.
Totally.
So I don't think, like, one of the questions that I often get with patients is, do you see antibiotic resistance with herbs?
And I can't say that we do. I think occasionally they may stop working for lack of a better explanation because the body gets used to it, but then it'll start working again later. But I can't say I've seen research on resistance formation from a whole plant, like artemisinin, for example. There's resistance that is formed, but artemisia, so that's why, we generally, I think, prefer to use the whole plant when we can.
What about for yeast?
You mean for natural compounds?
So just so you guys aren't in the room with us, the closet, if we're honest. You guys aren't in the closet with us, but literally, Rebecca looks right at Ami, and she goes, "How about fungus?" Like, Ami is by no means, like, there's no question. If there's a question about yeast, mold, or fungus, Ami is...
You mean about resistance?
Yeah, with herbs, because I find I often have to rotate herbs.
I don't think that's resistance well, so here's the thing. The way that I learned about it with fungal organisms is they reproduce at a much slower rate than bacteria. There will be some species or yeast or fungal organisms that are resistant to a particular agent that you're using, and while you're using that agent, those will grow more, but they're typically, in our world of sort of non-hospitalized patients, they're typically genetically weaker organisms. So if you then pull that agent, they'll kind of die off on their own or become
Fungus is...
So the way that I learned about it from a microbiology review that I had read was that those species or particular organisms that aren't targeted by the agent you're using, they are resistant to that agent, but they're a minority usually if we've picked the right agent.
So it's not significant enough to really matter.
It's not significant, but if you've used that agent then for 6-8 weeks, that number of resistant organisms can become more potentially their population can increase because you're targeting A, and B is the group of resistant organisms. So then if you pull that agent, B will slowly, A will start growing again, B will kind of go back to the lower amount of organisms. That's how it was explained to me. And then you could potentially use the same agent again. But so I don't think of it as that we're creating more resistant organisms. It's just some are going to be intrinsically resistant to the agent you're using.
Would it be smart then to do more of like a multifaceted approach where you're coming in from different angles?
There's different approaches. I I like to keep things simple, so I tend to use one agent if it works, and then pull it once in a while.
Yeah.
Or over time try to find a few that someone does well on,
Yeah.
and they can rotate them, not because we're creating more resistance, but because there's intrinsically resistant organisms that are going to be there
Yeah.
for any group
Yes,
of bugs
yes.
we're treating. Of course, this is different from like a hospitalized patient where that
Yes.
resistant organism could kill them.
Yep.
This is more in our, I have long-term symptoms.
Immunocompetent patients.
Immunocompetent patient where there's going to be some just resistant organisms to any agent we use typically, right? In our immune system, just like with bacteria, and we use antibiotics, that antibiotics aren't always bactericidal and that antifungals aren't always fungicidal.
Right.
Our immune system is playing a role too, which is why if they're not immunocompetent, that, the rules are different then.
Yeah.
And this is a whole nother topic,
Yeah.
but I was, when I was researching treating blastocystis hominis, the treatment that we use, which is nitazoxanide, is not it's not anywhere near 100% effective at eradicating it. The person's
Right.
immune system has to pick up at least 30-40% of the work, and then the agent can help, which is why they typically don't recommend treating it unless someone's immunocompromised.
Right.
But a lot of our patients struggle with GI dysfunction, so that's a whole other thing. But our immune system competence and terrain is almost equally important as the drug we're giving.
If you ask me, like, what was the catchphrase from when I was at school, it's not the bug, it's the terrain.
Right.
It's not the bug, it's the terrain, which brings us back to biofilms.
Right.
Because biofilms are literally the terrain.
Totally.
Like, that's what we were talking about.
Yeah.
Okay, so let me take a high view. Let me just bring us back. We talked about this is multi-species, multi-diverse, complex communities that form within the body and outside. There are physiologic, healthy biofilms that help us live, and there are also pathologic biofilms. At this point in history, we are doing a really good job giving the pathological ones a hand up because of our diet, because of our lifestyle, because of our pharmaceutical options. And by the way, we didn't even discuss what psychotropic meds do to the biofilm or to the microbiome.
Do you want to give us a quick preview?
Yeah,
on psychotropic meds and
So one of the theories that are actually, getting some traction right now is the way that psychotropic meds work is actually by affecting the microbiome, right?
You're talking about SSRIs in particular?
SSRIs, SNRIs,
It makes
atypicals
so much sense because the first thing you usually get is diarrhea.
or constipation.
That's
Or
true.
nausea. Like, your gut is absolutely involved.
I guess I
And all
assumed
the
it was
serotonin
related
and
to
dopamine.
neurotransmitters, but maybe via biofilm in some
I
way.
mean, you can't say, if you're having a conversation about bacteria, you just can no longer assume that there's the majority of your bacteria is planktonic. You can't. The majority of your bacteria is within a biofilm state. The majority of humans live in cities or towns or suburbs, and there's a small subset that are rural living. You know what I mean? But it's not like, generally we are beings that live in communities.
Right.
That's times a billion for bacteria.
So, how do the drugs get to the biofilms?
So, okay, I think we're going to do treatment in a separate episode
Okay.
because I think there's
But
enough.
even like SSRIs,
How
how do they shape the populations?
because there are always bacteria in the planktonic state, and it's not like the biofilms. It's not like the walls are so thick.
Yeah, when the bugs go back home after a
Yes.
day at work.
And
Wait, you said bacteria are always in the planktonic state. Did you mean they're always in biofilm?
Bacteria are generally in the biofilm state.
Gotcha. Okay.
Generally
convert.
speaking. So the way that it works is a bunch of bacteria form together and they form like these weak bonds, and that's like a phase 1 biofilm, right? It's like they're like, oh, we think, they're like scoping out the
It's
land.
like dating. They're dating.
Okay, yeah, I was thinking, what do construction people do when they're like deciding to build on a spot or not?
It's not my
Were they like,
metaphor.
Or like
yeah.
evaluating the land.
Yeah, they're like evaluating the
potential.
land. Exactly. Like so
Surveying.
That's surveying. That's the
Yeah.
word I was looking for. So they start, a phase 1 biofilm starts in the surveying state where it's like, some of them are there, but it's pretty weak, and they're not, the walls are there, but it's more like a tent. It's not like a, skyscraper. And then enough bacteria come and there's enough quorum sensing happening, and they're like, okay, this is it. And then they change that bond, and it's a very, very strong bond, and they build all of these walls, right? And they build walls around the city, and then they build buildings, and they bring stores, and, arts places, and, the arts come and everything. And then the black market comes, because that's what happens. And then all of a sudden, that community gets way too populated, right? And then they all make a decision based on quorum sensing, and they say, this is too populating. And so they kick out like a third of the bacteria that's in there. Now this bacteria is back to being a planktonic bacteria in a single-celled organism, and it floats by until it finds a new place to to come into. So that's how biofilms get formed, get destroyed, reform, get destroyed. Like there's constantly this flux that's happening, and that's really what predicts like what bacteria is planktonic, what bacteria is biofilm.
Okay.
Does that make sense?
Yeah, totally.
So I think that with antidepressants, with cardiovascular medication, with one of the big ones that we're talking about right now is like the weight lowering medications.
Oh, yes.
That's also affecting the microbiome.
Right.
We are and then like our diet and like we are definitively giving pathological biofilms the upper hand. Period. Full stop.
Yeah.
So let's go back to like a little bit of a higher view, right? Let's talk about diseases or conditions that we know have biofilms as one of their causative agents. We talked about plaque on your teeth and gingivitis, chronic ear infections,
Totally.
chronic
UTIs.
chronic
Yeah,
UTIs,
sure.
chronic intestinal issues, chronic bacterial vaginosis, chronic mastitis with nursing and lactating women, chronic bronchitis, chronic pneumonias. What's the one word that has everything in common?
Chronic.
Chronic sinusitis.
Chronic sinusitis.
Yeah.
And that's, I think this is the thing that's really important for like us clinicians is the longer the pathology has been here, the more chronic it is, and the more complicated it is, the more we're going to have issues treating it.
And depending on what we've done, maybe the stronger it is.
And depending on what we've done, maybe the stronger it is.
Like we made the biofilms worse by throwing short courses of,
They almost
you know,
conditioned us.
something or
Again
the other.
and again
Yeah.
and again.
Cipro.
Yeah.
Just throwing Cipro.
Right.
at
I mean,
UTIs.
it's the typical, you know, you have someone come with a UTI and you go through their culture and it's resistant to everything and there's like one drug left and that's a pretty
Cross
scary
your
situation.
fingers, send 'em home.
Yeah.
Yeah. I mean, yeah.
Which is maybe when plant-based herbal medicines might be more like almost a necessary complement when there's almost no antibiotics left that are going to work for it.
And prevention.
Right.
You know,
Right.
or potentially biofilms.
Yeah, I mean, I also want to say that in my clinical practice, the amount of women that I've needed to give antibiotics for their urinary tract infections,
Yeah.
what, 10%?
Totally.
Maybe less?
Yeah. Unless it's like frankly in the kidneys.
Yeah.
And that
Yeah.
would be a good episode just to go through.
Oh, yeah. How do you treat it? I mean, I feel like,
That's
yeah.
a great idea.
Okay,
It would be
we'll put it on the list.
So
helpful.
microbiome
Yeah.
based.
we'll put it on the list. So that's absolutely right. I do believe that herbal interventions for a lot of these chronic conditions, I personally feel a lot more comfortable with them as long as you know when you're looking for your risk factors and as long as you know when that line has gotten crossed where it's not safe to do these lower side effects, but also, lower
Slower.
intense
Yeah.
protocols.
Right. And you always want to give both options to the patient and they can help you decide what they want to do, knowing the risks and benefits and the potential resistance patterns, as long as you've done your due diligence.
Yep. So the take home really is chronicity. And, that's also important to remember because not all infections are created equal. Not all infections are created equal. And not all patients have the same immunocompetency.
Right. So you have to keep the host factors in mind when you're treating.
So tell me what kinds of bugs can form biofilms that we know.
Do we want to do that in this episode or the treatment episode?
Oh. Well, I want to know if archaea
What do you
this.
mean? What kind of? You mean like what
Yeah, like we've
classes
talked
of
about
organisms?
Yeah.
Yeah,
I'm
we
going to
talked
talk. I have
about-
lots of
Okay.
bacteria.
Like, do we know
Okay.
specific types?
I suspect archaea would do it as well. All of the different.
Okay, we're gonna do it in this episode.
Okay.
We'll do treatment. We're
Delegation.
gonna do bacteria species in this episode, and then maybe we'll revamp it in the next episode. Just
Yeah.
as a quick Okay, so I'm gonna start with a disclaimer that I run a GI based practice, right? And because of that, I am mainly looking at what bugs within the GI do this, right? So when I did my literature search, I basically did a good look at what was available for me to find in the testing that we had. And I think we're going to do testing and treatment for the next episode.
Great.
What bacteria that I could find on testing and where I landed. The most important thing that I ever landed on was Pseudomonas. If you see Pseudomonas, period, full stop, do not pass go. Do not collect $200. Just, you have to treat it. And I came to this for a couple of different conclusions. I am lucky enough. I have a lot of people that, will circle through and do a rotation with me or like observe me or whatever. And I had this really, really smart nurse practitioner come out. This was, I don't know, like,
about 2 years ago.
No, it was like maybe 5
Really?
or 6 years ago.
Oh.
Yeah, because I've been lecturing about
Different nurse practitioner,
biofilms.
maybe.
I've been listening about biofilms for, I think I started lecturing about 4 years ago.
Okay.
So she came through and we were watching and we had a patient come through and she was like, I swear to God, dude, Pseudomonas, it's like the worst. Yeah. And then I started talking to my colleagues and I started talking to other medical doctors and surgeons. And whenever I would bring up Pseudomonas, they would basically say, Pseudomonas is the worst because like on skin, like on open body surgeries, when there's a Pseudomonas overgrowth, they will form this intense, rigid, hard
and in
plaque.
the lungs. They do it in the lungs. Yeah.
Yes.
And what's interesting is when I'm doing all my research on like gynecologic conditions and the microbiome, which is my favorite thing in the world, Pseudomonas is elevated in almost every condition I look at.
I guess my one question is if the Pseudomonas is in biofilms, then are you necessarily going to even see it on any of the testing that you do? I know you do, but I mean, are you also missing it?
I'm going to talk about provocation when we talk about testing our treatment episode.
Okay, sounds good.
So Pseudomonas. Pseudomonas is my first do not pass go, do not collect $200. I see Pseudomonas. I've got good treatments. Spoiler, it's coming in the next episode. I've got good treatments for it. And it always hints me that there is not only a biofilm happening, because anytime there's a chronic condition, there's probably a biofilm happening, but that biofilm has a really, really thick, big plaque around it. Right? So it's going to be a difficult biofilm to resolve.
So Pseudomonas isn't normal to have in our gut?
I think that it has I'm sure that in small amounts, everything is normal, and the more biodiversity we have, the better. Right? So I never want to say no.
So if people have Pseudomonas and are symptomatic,
right. I mean, it would be nice if we had a bunch of results, PCR results for patients who have no symptoms to see what is the prevalence.
I mean, I'm sure you have folks who come in with a stool test already done, and maybe they don't have GI symptoms anymore. Yeah.
Oh, right. Anymore. Gotcha.
Or some other provider.
I don't know if I would treat it. Like, generally speaking, if I'm running a test, I'm running a test because they're symptomatic. Right. I don't spend the money on...
Right.
I'm not looking for control. I'm not running clinical trials. Yeah. And if I see it, I'm going to treat it.
Or if they're not actively symptomatic, put it on the back burner, and as things ramp up, if they ramp up, then we know
someone probably treated them, and maybe they treated it by way of whatever they used, you know?
I feel like a lot of people order these stool tests and really
they don't do anything?
what they're doing.
But then you just see the patient and they haven't been treated for anything, but they're feeling better.
Their results. Yeah, or it ebbs and flows, and they're just not really in a flare.
I cannot agree with you more. I see so many people coming in with, I spent $300, $400 on a stool test.
Sometimes they're self-ordering some of these tests that I don't find helpful.
Or people order them who can't interpret labs, and then
there's that too. But there's all of these direct-to-consumer tests now, and I wish patients would check in with us first, just because we'd have better way to use their finances.
For sure.
Yeah. So. And speaking of the provocation,
we're not provocation. We're going to go with testing and treatment. Different episode. Okay. So Pseudomonas is big. Yep. Klebsiella is also exceptionally well documented to cause biofilms. Right. Klebsiella used to be a much bigger problem, like any community exposed lung infections used to be Klebsiella back in the day. Now they're mainly hospital based. Klebsiella is a big deal for me. C. diff.
Yeah.
C. diff we know about C. diff and biofilms. There's some information, and then also the pathological ones. We know Salmonella has a tendency to do this. E. coli has a tendency to do this. Vibrio has a tendency to do this.
So, do you think with the C. diff, the research on the stool transplants is basically working on biofilm?
I think it's definitely part of it.
Yeah.
Yeah, you're trying to give the upper hand to the diversity than you are to the single monoculture.
Desulfovibrio, you said.
Vibrio cholera.
Oh.
Sorry, Vibrio cholera. That is a really good.
Well, I was like, hold on.
Yeah, that is a very good. Thank you. That is a hugely good clarification. So those are my bad guys. Staph and strep. Yep. I consider. The way I describe staph and strep is they're not inherently bad guys.
Right.
And if they're in a good neighborhood, they're probably going to be just fine. Mm-hmm. But if they're in a bad neighborhood, they are not going to be just fine. They are going to turn easily swayed. Yep.
Pushovers.
I think that's, and then the other one that I often think about is Candida. Mm-hmm. Candida is the communication for virtually every bacteria. It is everywhere. We know that it turns infections chronic, virtually every part of your body, from your ears to your eyes to your vagina to your GI to your da-da-da.
And
skin.
like you said, it totally hijacks your brain.
Yeah.
It feeds itself. It's
Yeah,
amazing.
it's amazing.
What about protozoa?
Protozoa will live in these communities. I don't know if I've seen literature on biofilms and protozoa.
Like maybe they can't produce the biofilm.
Don't ask me. These are great
maybe
questions.
Maybe that explains part of why it's somewhat easier to eradicate protozoa than some of these other chronic.
I also, the way I think about parasites or Giardia in particular is they're not changing your tissue. They're changing the microbiome.
And a lot of people have it and don't. It's not nearly anywhere close to 100% of people who have it who have symptoms. So there's these other factors, like you said, the host factors that are determining.
The host factors are always determining.
Yeah,
it's not the bug; it's the terrain.
I was actually. This is another episode too. I was surprised that I can't remember exactly. I think it was around 30% of people don't have symptoms from it.
Yep.
So it's definitely not just the bug.
Yeah.
So those are kind of my big species that I'm always looking for. I'm going to say that, last time I looked, it was probably 4 years back. And when I pull data, when I find species coming up on different stool tests, and I pull data, like I found data on Bacillus. Bacillus seems to form a biofilm.
Yeah.
So, so what I generally do, the way I move forward is I know my bad guys. I'll always go after my bad guys. Mm-hmm. And then if something comes up that I don't know about it, I just go right to PubMed and I see if I can find literature on it. And not all the species that we find in the stool test have literature on biofilm capabilities. But if they do, that does give me a way to shape my treatments.
I feel like Bacillus is positive across the board.
I feel like Bacillus is positive a lot too. And so I give that a little bit of
Okay.
I agree with you. I feel like Bacillus is always positive.
I'm just not. I don't know that our reference range is.
I also think that me and you are using the same stool test for testing, and they might be. I'm assuming that they're particularly sensitive.
Although again, people who come in, I've seen it elevated on other tests too. Not the same number.
Yeah.
But
yeah.
Have you two run the urinary PCR testing for some of these chronic bugs?
No, have you?
Okay, I have, but I found it to be challenging to clinically apply the information I'm getting.
That is a challenge for sure. Yeah,
for many tests.
I know I keep going to this, but is there a provocation for urinary?
Yeah,
you probably could do the same provocation that we're going to talk about for GI.
Well, about NAC.
Let's talk about provocation.
Yeah.
I feel like
do it in the next.
I feel like this is a conversation that I want to have that we can't fit on one episode.
Okay.
So why don't we? How was that as a foundation of what other
good.
questions? What are the questions? What else is out there that I didn't get to?
Well, besides the obvious, like
besides the treatment and testing, yes. Besides the obvious.
So, I mean, you're thinking about the trick is remembering to think about this. So, thinking about biofilms when someone has any chronic infectious related sort of symptomatology in any part of their body is to think about is biofilm part of the reason why they keep relapsing or having recurrence of symptoms. And that's basically, I think, been my main challenge. Is remembering to think about it.
Alana, in your perspective, like, let's say someone comes in with chronic urinary symptoms or chronic ear infections. Are you looking at the gut? I am looking at the gut. Of a correlation? I mean, I would say obviously, but I'm wondering if you see that.
I can tell you that when I pulled all my data, were they looking for GI manifestations of extraintestinal presentations and bacteria? No, I never saw that data. Sure. They were looking to not culture, to PCR the local chronic infection.
Yeah. And it could be a chicken or the egg sort of thing, because if someone has recurrent ear infections, recurrent UTIs, we're blasting their gut with antibiotics regardless. Right. So.
And I am exceptionally biased, and I understand my own lens, and my own lens is that it all starts in the gut.
Yep.
I also generally treat GI exclusively, and so I think it all starts in the gut. Yeah. So,
and I feel like most of the world has come around to the microbiome being the sort of central point for so many different areas.
I just want to give a little side note. There was a while before Facebook became very toxic to me. There was a point where Facebook became very toxic and I stopped going on it. But I used to do this I call it like an blast. Like whenever I'd see a study that basically was like, oh yeah, we've been talking about this forever, I'd put it out on Facebook and I'd say, science, quote unquote, discovers what naturopaths have known for decades.
Right.
You know what I mean? Like, and one of the things we have known for decades that we've been preaching and we've been called quacks about is it does all start in the gut.
And I do think it's coming around. It goes back to Ayurvedic medicine as well. But I feel like most practitioners these days would agree, just digestive health, what we're eating, etc.
All up to date on research.
Yeah. There's quite a bit of research.
Or common sense. if you're at all up to date on
We don't
common
all
sense.
have- yeah.
Any other questions for me before you guys give us a recap?
I mean, I feel like we just have to start another episode.
Okay. What's the recap? Do you guys want to give us the recap?
A lot of bugs can do this. It's really scary. They essentially can work together to create their own shield against anything we might try to treat them with, and it expands to pretty much every system in the body.
Right, and there's healthy and unhealthy biofilms in our world. Obviously, when someone's symptomatic, we're thinking there might be unhealthy biofilms if there's a chronicity to their symptoms in really any body system, and there's quite a bit of research on manifestations of that and how it makes these organisms difficult to eradicate.
Okay.
Brilliant.
Okay.
Thanks, guys.
Stay tuned for part 2.
Thanks for joining us today. Stay tuned. We release episodes every 2 weeks.
If you like this episode, please subscribe and don't forget to rate and review us to help spread the Turd Nerd word.